Okay guys, last video I hope for renal clearance. So how do we adjust when we have patients that are in renal failure? We know we're going to have to adjust for patients that are on drugs that require the kidneys for the clearance. So sorry, I guess I have to do a little homework here and clean things up. So adjustment in renal failure. Oh, shoot, sorry. Keep hitting the wrong buttons. You'd think I'd have this down by now. So the first thing we have to do when we're going to adjust our drug dosing regimen in patients with renal failure, the first thing we have to do is we have to know something about the drug and something about the patient. What we need to know about the drug is the normal total body clearance of the drug and the fraction that is excreted unchanged in the urine. If the drug is not excreted unchanged in the urine at all, so if Fe is equal to 0, that means that this drug is not dependent upon the kidneys at all for clearance, so we don't really need to make a dosage adjustment renal failure unless there is an active metabolite that is cleared by the kidneys. Then you have to pay attention. But if it's cleared by the liver, which is indicated by this Fe of 0, then we know we don't have to worry. So it's important to know how much of the drug is cleared by the kidneys and the normal total body clearance of the drug. So that's what we need to know about the drug. What we need to know about the patient is an estimate of their renal function, how well their kidneys are working. And we do this by getting a creatinine clearance. This measure of creatinine clearance is just an estimate. This is not actually measuring creatinine clearance. This is using Cockcroft and Gault, which uses population information to measure or to guess at what the creatinine clearance is for the drug. Well, what does creatinine have to do with kidney function? Well, that's a good question. I will tell you. If we wanted to easily measure our kidney function, one way we can do that is by measuring our, we want to know what our GFR is. What is our glomerular filtration rate? Because our glomerular filtration rate measures our renal function because of what we call the intact nephron hypothesis. So the intact nephron hypothesis says that any of the nephron isn't working, then none of it's working. So if the filtration is not working, then the whole nephron is dead. So to measure the GFR, we know that filtration clearance is equal to GFR times fraction unbound. If we have a drug that's totally unbound, then our filtration clearance is going to be equal to our GFR, isn't it? And if our drug is totally cleared by the kidneys, so our total body clearance is equal to renal clearance, and if we don't have to, if the drug is not secreted or not absorbed, then renal clearance is going to be equal to filtration clearance. And so then total body clearance will be equal to GFR. So, and that gives us our measure of filtration clearance. Now, again, we're not saying why creatinine yet. Well, in order to measure this, we would, like we said, we want a drug that's totally cleared by the kidneys, that's totally unbound, and is not secreted and not reabsorbed. There is a drug like that we could give and measure the total body clearance by doing dose over area under the curve and get total body clearance. But people don't like to give drugs to determine renal clearance. Well, the cool thing is we have an endogenous compound that is made constantly in our body, and it is called creatinine. That endogenous compound is totally cleared by the kidneys, is totally unbound from plasma protein, so has a fraction unbound of 1. And there is some secretion, but not too much, and is not reabsorbed. So by measuring the total clearance of creatinine, we get a very good measure of our GFR. So that's why we measure creatinine to measure the clearance of creatinine to get our renal function. All right, so erase all and do that and do that and do that. Okay, so it's really also quite important for you to know that this is just a guess, isn't it? This is just a guess. This is not a measurement. Okay? And you all know this, you should all have this memorized. 140 minus age, which is age in years, the body times ideal body weight. Why is it ideal body weight and not actual body weight? Well, did I tell you this? That creatinine, I meant to tell you, but I may not have, is made because it's a breakdown product of muscle. So if someone's very overweight, we don't want to anticipate that they're going to have a lot of muscle breakdown for their weight that they are. So this is based upon muscle weight. Okay? And we'll talk about this. We'll come back to the weight situation. This is compared to your serum creatinine times this fudge factor of 72. And we multiply the whole mess times 0.85 for women. There's people that really like this. There's a lot of evidence that it isn't that accurate, but this is what is pretty ubiquitous. And you need to know it and use it and have it memorized. Now, what do we use for this weight? We use ideal body weight unless, I'm going to just go to a bigger piece of paper again. We use ideal body weight unless the actual body weight is less than ideal body weight. Obviously, then we're going to use our actual. We're not going to make up some ideal body weight if they're actually less than that, right? Because that means they even have less muscle mass and less creation of creatinine. We also don't use ideal body weight if they are considered obese. And obese is 1.3 or 30% over your ideal body weight. So you take your ideal body weight, multiply it times 1.3. If they are obese, then you have to use what we call an adjusted body weight for that. Your adjusted body weight is your ideal body weight plus 40% of the difference between your actual and ideal body weight. So I call this the fat weight. Is it all fat? No. But your actual body weight minus your ideal body weight is all the weight that you're over your ideal body weight. You take 40% of that and add it to your ideal body weight, and that gives you the weight that you use for determining creatinine clearance. Okay, and you guys should just know that. From now on, you just got to know it. Okay, so that's Cockcroft and Galt. You get your estimate of your patient's creatinine clearance. So you determine your patient's creatinine clearance. Let's just say that it's, let's say your patient's creatinine clearance is 45 mils per minute. Okay? And then anything with an asterisk, that means that's your patient's creatinine clearance. Okay? Then you use your patient's creatinine clearance and you compare it to the normal creatinine clearance to get your patient's renal function. Okay, so in this case, it's going to be 45 mils per minute. Remember, what's a normal GFR or creatinine clearance? 125 mils per minute. Okay, so what's 45 divided by 125? It's 0.36. So the renal function is 0.36. What that tells you is that about 36% of your nephrons are actually working. So your patient's renal function is about a third of their nephrons are working, so they have some significant renal impairment. Now determine an adjusted clearance for your patient. So again, this little asterisk means it's your patient. So you take whatever clearance, the normal clearance of a drug, times a quantity, 1 minus FE, so what percentage of the drug is dependent upon the clearance of the kidneys, times 1 minus the renal function of your patient. So this is your patient, this is about the drug, and this is about the drug. This will give you an adjusted clearance for your patient is an estimate of your patient's total body clearance. So once you have your patient's creatinine clear, or your patient's adjusted clearance, you put it in here and get this is your target concentration. Here's your patient's clearance. You put in the bioavailability and solve for dose rate. This is just moving this around, right? So what your target concentration is, your patient's clearance, which is going to be less, right? Therefore, since you're going to have a lower clearance, you're going to have a lower dose rate. Same thing, put in this adjusted clearance in for half-life to determine your half-life. A better estimate of your, and you dose usually about every half-life. Sorry. All right, that's it, and that's how you can make an adjustment for a patient with renal impairment. We'll do some of these practices in the workshop and in your homework. Okay, thanks.